Good evening.
Good evening.
Good
Good
evening.
evening.
Sir, John, sir, good evening.
Good evening.
I'm also inside, but then I don't have an. Hello. Good evening.
Yeah, I hear
Hello.
you. Okay, I'm trying to get you in.
Yeah. Okay, as a panelist. Yeah, because I'm.
I think you are already there. You are already there, Dr. Narayan. And therefore, I don't know, because I've seen your name. And yeah,
Yes,
you
sir.
are.
I'm inside. So,
Okay.
good evening.
So-
Good evening, everybody. Good evening.
Yeah,
Good
Dr. Swami is ready to do dress inspection.
Yeah, I know you know. I don't want you to point out me, so I should be punctual.
No, I don't want to embarrass anybody or, put anybody.
Yeah, it's good. Good to be like this.
Yeah. I know it's a change.
I think I'll call Dr. Dev Pujari. He will join, and also
Okay.
Dr. Swal. I'll call him.
Tell Chandra to shake a leg.
Yeah, yeah. Dev Pujari, sir, Dr. Chandrasekhar, yeah. So I'll call him.
Okay, I'll be back in a minute.
अच्छा ठीक है सर प्लीज ओके सर थैंक यू ओके सर ये जायसवाल Dr. Jaiswal Avdesh has joined already. I think we have to allow him as panelist. And also, sir will be joining Professor Dev Pujari. John sir, please allow him Dr. Avdesh as a panelist.
Okay, I'm allowing everybody, and it's up to them to accept the invitation that I asked them to come in the panel. And I don't see Dr. Dev Pujari yet.
Dev Pujari sir will be joining. He said he has opened the computer and maybe in another 5 minutes or so,
Oh, okay.
he will join. So meanwhile, may I see my slides? If
Yeah, sure. Go ahead.
it works very well.
Yeah, we have a few minutes. We have 7 minutes. We have lots of time.
Yeah, Avdesh.
Welcome, Dr. Avdesh.
Welcome, Dr. Avdesh, Professor Avdesh. Thank you very much again. So I'll just see whether my slides are working all right or not.
Yeah, go ahead.
सर वो बैकग्राउंड कैसे करते हैं हमको आता नहीं है
क्या
बैकग्राउंड
background? I think you have to go in the settings and then my daughter has done it for me. And then
Yeah.
Avdesh, you have to first of all download STPJ photograph and then go to settings. Okay. And from settings, select the photograph. Maybe not in this, do it for the next time.
ओके सर थैंक यू सर थैंक यू
setting there will be blur and this thing and the others. I think on the left side there is others. So there you can see that I mean upload the file. So you
ओके सर नेक्स्ट टाइम आई विल डू इट
okay, please. So am I mean this is audible, I think.
Yes, sir.
This is seen. So
Slides
I'll
are okay.
see-
Yeah, it's
Slides are
fine.
okay.
It's fine.
I'll see my video is working or not.
Okay. Do you have any voice in the video?
No.
Okay.
I'll speak, describe myself.
Okay. It's
No
going
voice.
okay. It's going
No voice.
fine.
Is that okay?
Yeah,
Yes,
fine.
sir. Fine, absolutely.
Then it should be no problem. So I stop. Same way other videos are also there. This also must be working. Is it seen well?
Yes, it's fine.
Okay. Then this is the third video, that's all. So I think, yes, polite seal is seen well. It is all right.
Yeah, very good resolution there.
Okay. So thank you. I think I stopped sharing.
Right.
Yeah, so we can now discuss what is to be done and how we go about the whole thing.
ये मैंने नहीं पिया था पिया होगा यार वहाँ तो उसने वो पानी है सिंपल पानी है ये पानी पी गया था
John, I think you introduced Professor Yadav. I'll introduce the other two.
I'm sorry. Once
Will
again,
you-
I think we do the same thing. He introduces you.
Okay.
Yeah.
Professor John, sir. And then you introduce three of us, short introduction.
Done, sir.
So you're the key, Dr. Swami.
Done, sir.
You're the key to the operation.
Okay.
Oh, here's Chandra. Here's Chandra. The only couple of panelists this week, right? Sure.
Not correct.
Chandra, did you get in? See, I'm having trouble getting you in. I don't know what's going on. Oh, there.
So should I call him again, whether he's
No,
trying?
no, he's
or-
here. He's here. He's here.
He's here, okay.
He's here. I just can't get him in. Oh, here he comes. Here he is.
Thanks, John. I am in.
Oh, good, Chandra. We were wondering where you were. I kept
Sir,
clicking you
welcome.
in.
Welcome,
No,
sir.
no.
Welcome.
Maybe
Sir.
I pressed the wrong link.
Yeah, no, you got it.
Good evening, Dr. Yadav, Dr. Narayan Swami, and
Good evening, sir.
Yashwant
Good
sir.
evening. Good evening. Good evening, sir.
Sir, good
Good
evening.
evening, sir. Good evening, sir.
And welcome, sir.
Grateful, sir, that you are here. Thank you, sir.
Always a pleasure. मैं ही अकेला हूँ जो टाई वाई नहीं पहना हूँ, लेकिन चलेगा शायद.
You are on
Sir,
Sherwani, sir.
Sir,
You are on Sherwani.
you are looking so good. Sir.
आप पहुंच गए वापस जबलपुर की कलकत्ता में ही हैं?
No, sir, I have come to Jabalpur.
Okay.
At about 5, I had to take 2 flights. So every Sunday is like that. I am somewhere and then I have to get up early morning and come to Jabalpur.
वो फिल्म स्टार जैसा वैन बना लो आप, उसमें पूरा सब इक्विपमेंट रख के.
Vanity van.
हाँ, that's right. So how are you, John?
Good. How you been, Dr. Dale Pujari?
You have the Chinese that program is over or it is starting
Yeah,
now?
yeah. This morning we had that this morning. Just finished it.
I had some guests at home. Otherwise, I was quite keen to hear the guy for hydrocephalus.
Oh yeah, from Boston. From
Hmm.
Boston. You know, I don't listen to a lot. I just worry about getting it, keep it going.
It's available on the YouTube, sir. So
We already have 20 people.
Balfour.
Eh,
Balfour.
And then there are people on YouTube also, sir.
Ah,
Yeah, as many don't even register, they just watch it. Because they don't have to register, they don't have to, go into Zoom. Okay,
So-
you ready, Dr. Yadav?
We
Yeah.
can start, sir.
Okay, let me get it going. Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2. Good afternoon, this is Dr. John Bennett, broadcasting from Miami Beach, home of Neurosurgical TV. We have another episode in the continuing series on neuroendoscopy by Dr. Yadav, the president of the Neurological Society of India. So first we'll introduce Dr. Swami from
Good
Jabalpur.
evening.
and he'll introduce the rest of the crew. Thank you. Thank you. Welcome.
Yeah, good evening, everybody. Welcome you to this 7th episode of ongoing series. Today, Professor Yadav has obliged us in speaking about intraventricular tumor. And we're also honored that we have two neurosurgery, neuroendoscopy, Professor Dev Pujari and Professor Avdesh Jaiswal. And Professor Yadav, as you all just have been introduced, that is the president of NSI. He has taught almost all the younger generations of the younger neurosurgeons of India. He has trained them in neuroscopy. He is a great teacher. He has written many articles. He has got a lot of achievements. I don't know exactly what exactly I should speak of. He has introduced the fellowship. He has upgraded the neurosurgery department. We just started from scratch to the state-of-art institute in Jabalpur and has made it worldwide. Thank you, sir. Thank you. And we're also having the founder father of this Neuroendoscopic Society, Professor Chandrasekhar Devpajari, is from Mumbai. You all know him. He doesn't need any introduction. And sir finished his graduation from GMC. After that, he has got himself trained in Newcastle upon Tyne as well as Detroit, and has done many fellowships. He has been the past president of Neurosurgical Society, plus the founder father of the Neuroendoscopic Society. He is the chairman. I was in the WFNS Society also for the Neuroendoscopic and the minimal invasive. If I keep on speaking, probably I can keep the whole webinar speaking. Thank you, sir. Thank you. And
Thank you.
this is the
Thank
talk.
you.
And similarly, we have one more giant, Professor Avdesh Jaiswal, who is known over the India and the world for his techniques in intraventricular tumor and other neuroendoscopic procedures. Thank you, Dr. Avdesh, and you demonstrated.
I think,
Sir, thank you.
Dr.
And we'll be honored to have you as a panelist. And not wasting time, I'll hand over the mic to Professor Yadav. Sir, please.
Okay, thank you very much. I think, Dr. Swami, you have to be a little closer to the
Mic.
yeah, your voice sometime was not so good. So
Okay.
thank you very much once again. I am grateful to Dr. John sir for giving me this wonderful opportunity to share my views, and also I'm grateful to Professor Swami for moderation of this session, and also I have no word to express my gratitude for Professor Dev Pujari sir. I have learned endoscopy from him. So thank you, sir. Thank you very much. And again, we have a giant in endoscopic surgery from SGPGI, Dr. Avdesh Jaiswal. He is doing wonderful work. And again, I must say that I am today topic is the endoscopic surgery for intraventricular tumor, in which I use either channel endoscopy or tubular retractor, and the indications I'll be sharing. But Dr. Avdesh Jaiswal has gone even one step ahead. He doesn't use any retractor at all. So I mean, it will be very nice to have his comments. And Professor Dev, you know, he started endoscopic surgery in India, including training. And again, I am repeating that I learned from him. So thank you, all of you. Regarding the intraventricular tumor surgery, the intraventricular tumors are the ideal indications for endoscopic surgery. These lesions cause CSF pathway obstruction, resulting into ventricular dilatation, which provides sufficient space. So the one important thing in endoscopy is that you should have a space to work. So because there is a ventricular dilatation in most cases, therefore it is an ideal indication for endoscope. and for instrument manipulation. Regarding the tumor surgery, the general principle is that you interrupt the blood supply first so that there's no bleeding or less bleeding, and then you can take out the tumor in piecemeal, unlike general surgery or other procedure in which you take the tumor out in toto. But this can be done if the lesion is small. The approaches, it's a very broad topic. So approach for intraventricular tumor depends upon the location of the tumor, the extent of the tumor, the vascularity, and the existing neurological deficit, and the displacement of the white matter tract. This is also very important. And I think I recommend this article of lateral ventricle and many more, in which the various strategies to take which approach is very nicely given. So we cannot obviously cover everything, but I'll be giving an overview of what should be done. Regarding the lateral ventricle tumor, we have the frontal horn, the body anterior part, the posterior part, the atrium, the occipital horn, and the temporal horn. So obviously the approaches depends upon the location of the lesion. If the tumor is located in and around the frontal horn, or near the foramen Monro and in the anterior half of the lateral body of the lateral ventricle, then you can take anterior approach, which could be either anterior transcortical, which can be either from the superior frontal gyrus or middle frontal gyrus. The advantage and limitations I'll be discussing later on. And you can have anterior transcortical. If the lesion is there in the posterior part of the body of the lateral ventricle and in the atrium, then you can take again the transcortical approach from the superior parietal gyrus, or you can have transcallosal approach with advantage and limitations. If the lesion extends posteriorly, you can extend it a little more posteriorly in the occipital lobe. If the lesion is there in the atrium, you can have again this superior parietal lobule, parietal lobe approach. You can also approach it from the inferior parietal gyrus, but there are limitations. Only, I mean, there are indications if there is intraventricular lesions, plus it is extending laterally and producing already homonymous hemianopia on the right side. If the lesion is there, then you can take the inferior parietal approach. But there are risks of language impairment on the dominant side, agraphia, alexia, acalculia, and so many things. So you have to take into account of the various structures which are coming in your way. Then if the lesion is there in the temporal lobe, then also you have different approach, which I'll be dealing with. Again, we all know that there are the visual fibers coming there in relation to the temporal horn. So you can produce that problem, and then on the dominant side, there can be auditory and the speech problem if it is a dominant hemisphere. So regarding the frontal horn or the anterior part of the body of lateral ventricle, we have discussed if the lesion is there laterally placed in the frontal horn, more laterally and going superiorly, then you can take either the middle frontal gyrus approach or the superior. Prefer the reasons I will explain later on. and there are studies available which supports the superior frontal gyrus approach. But the lesion is extending more medially, and if there is no ventricular dilatation, so if both the lateral ventricles are involved and there is no ventriculomegaly, you can take transcallosal approach also. If the lesion is going on the other side, again, middle frontal gyrus approach is more preferred because it is in the long axis of the tumor. So depending upon the tumor and its extension, you can take the approach. Plus, I have already said that you need to know in which directions those white fiber stacks have been displaced. So various approaches are there. I think it is beyond my, the present discussion. So regarding the superior frontal gyrus approach versus middle frontal gyrus approach for frontal horn and for the body of the anterior lateral ventricle, there was a study in which diffuser tensor tractography was done, and they found out the amount of damage done using two approaches, that is superior frontal gyrus approach and the middle frontal gyrus approach. The amount of damage to the callosal fibers was almost same, 7%, but superior frontal gyrus root disrupted less fibers of the allocated neural bundles, that is SLF2. The pyramidal authors have recommended that superior frontal gyrus approach is better. And as you know, that most of the cases, there is involvement of the frontal horn and the anterior part of the body of the lateral ventricle. So it is more in line with the superior frontal gyrus. So I prefer superior frontal gyrus approach in most cases, but there can be controversy. If the lesion is going on the opposite side, on the medial side, then you can have the middle frontal gyrus approach, and obviously the white fiber stacks. Regarding the atrium ventricle, we can have when the lesion is intraventricular and also going superiorly, then we can take superior parietal lobule approach, and you can deal with this. So intraventricular lesion with extension superiorly. And also, and if there is a intraventricular lesion and there is a medial extension towards the midline, then you can have parafalcine approach from ipsilateral side or contralateral side, as shown here. So tumor going medially, you can take midline approach either from ipsilateral side or from the contralateral side. But if the atrial lesion is extending more posteriorly, then you can have the posterior temporal occipital approach involving the occipital horn also. So those approaches. And if there is a lateral extension from atrium, the tumor is going laterally, then you can go from the middle middle temporal gyrus posteriorly, plus minus involvement of the occipital this thing. But you have to be very careful if it is on the dominant side, and if the lesion has already damaged that tract, then obviously you can take the shortest route. So a lot of thinking is required. If the lesion is there in the temporal horn, then you can go from the middle temporal gyrus or inferior temporal gyrus, but obviously of skull base, that is much safer. But even the middle temporal gyrus in superiorly, near the sulcus between T1, the superior temporal gyrus, and the approach has to be taken much more superiorly, so that the modified middle temporal approach can be taken, or if the lesion is more anteriorly, you can go for temporal lobectomy. If the lesion is going much more posteriorly, then you can have transtemporo-occipital approach. This is regarding the middle temporal gyrus. If you have to take middle temporal gyrus, it is advisable that you should be very close to the sulcus between the superior temporal gyrus and the middle. So the retraction of the fibers, and there is a less damage, and you should be parallel to the optic fibers, so that there is minimal damage. It has been seen that although it produces the optic deficit homonymous aminopia superior, but it resolves if you are parallel to the fibers of these optic tracts. But if you can come from the inferior temporal gyrus, then it is best, but you require a lot of retraction, and it becomes especially difficult if the lesion is there in the approaching near the atrium. Regarding the approach for the third ventricular tumor, again, we can have the anterior approach and posterior approach. In the anterior, you can have anterior transcallosal and anterior transcortical. I use superior frontal gyrus approach, and you can have posterior approach, transcallosal, and again superior parietal approach. You can come from the occipital transtentorial. That depends on the location of the lesion and the growth. And you can also have infratentorial supracerebellar approach if the lesion is posteriorly. If the lesion is suprasellar going into the third ventricle, you can also come from transsphenoid, and also subfrontal through the lamina terminalis, and other corridor also can be used to approach the lesions. When the lesion is there in the posterior third ventricle, we usually have two things that you require. There is a hydrocephalus and then biopsy or tumor excision. So the trajectory for ETV, so you can do two things. You can also relieve hydrocephalus, and you can take the biopsy or remove the tumor. But the trajectory for both, that is ETV, is different, and for biopsy or tumor removal is different. So there are various options. You can have two burr hole. So you can have incision, one single incision, but you can take two burr holes, one posteriorly placed near the coronal suture for ETV, and another burr hole which is little more about 4 or 5 centimeters away from that for biopsy or the lesion removal. Or you can have a single burr hole, especially when there's a large foramen Monro and huge ventriculomegaly, because there you can move your scope and taking advantage of working channel. If you use channel endoscopic surgery for ETV, you keep your working channel anteriorly and do ETV. When you want to do biopsy of posterior third ventricular lesion, then you rotate your working channel posteriorly, and then without little bit of, without movement or with the small movement which can be tolerated by the fornix, you can take the biopsy. The other option is that you can also have a single burr hole, use rigid endoscope for ETV, and to take biopsy, you can have the flexible scope. So you can have scope in scope. So you can pass flexible scope through the rigid scope, a working channel of the rigid scope, and take the biopsy posteriorly. Then you can also have a single bar hole and you use flexible scope. So you do ETV and both biopsy, because the tip of the flexible scope obviously can be moved, but the quality of image now, although it's not so bad, but still there is a limitation. But with the advent of chip on tip, I think this is going to have a lot of good images, and then we should learn this. The single bar hole with transchoroidal. So you can have a single bar hole, or the trajectory, but you can extend the foramen Monro. The problem is that for if you move it posteriorly, there is a chance of injury to the fornix. So if you go for transchoroidal approach, which can be done very well endoscopically, then you can extend foramen Monro and you can reach the posterior part of the third ventricle. Regarding the approach for the fourth ventricle, we can have transcortical, combined transforaminal and transchoroidal, which I have, and you can go through the transaqueduct, through the aqueduct, and remove the cyst, especially using either the infant feeding tube or any other tube. You can have both combined rigid and flexible scope, which I have discussed, the scope in scope. And then you can also have a rigid scope through which you can pass infant feeding tube, which Professor B.S. Sarma and other people have already described, that you can pass the infant feeding tube, and especially the intraventricular neurocysticercosis cyst can be removed. The occipital transtentorial approach also can be used for the lesions which are superiorly extending and also there in the fourth ventricle. There can be supracerebellar infratentorial approach and transverminal approach, which most of us were doing before. But now Tilo-Wheeler is more popular because it does not damage any neural structures. You can also use transcerebellar. So through the cerebellum you can go, but make sure that you are below the dentate nucleus. So do not try to injure. So you remain in the inferior part in the approach when you go through the cerebellum laterally. And now regarding the endoscopic approach, I have always been talking that there are mainly two types of endoscopic approach. One is the channel endoscopic surgery. In the examples are ETV and the intraventricular surgery of small lesions and which are avascular. So through the working channel you can operate. So this is known as channel endoscopic surgery. This is the example. So there is a endoscope and you have a working channel, you have irrigation channel, and you have outflow, and there is an endoscope. So in channel endoscopic surgery, the surgery also can be performed, but there are some limitations. It is a pure endoscopic surgery. The instruments are passed through the working channel only. So it's difficult to go for bimanual dissection. You have a certain angle at which you can introduce instrument, and it is through the liquid media. And therefore, if the lesion is very vascular and if there is a bleeding in the liquid media, it is very difficult to visualize. So therefore, the ideal indication for channel endoscopic surgery are either ETV or intraventricular tumor, which or lesions which are small or avascular or has the pedicle. So the vascularity is coming from the pedicle. So you coagulate the pedicle and then take out the tumor piecemeal. But if it is very vascular with broad attachment and intraventricular lesion, then you need either a port or a keyhole approach, which is also a pure endoscopic surgery. All the people call it microendoscopic surgery. But for me, when you use only endoscope and no microscope is used, then it is an endoscopic surgery. The instruments are passed by the side of the endoscope. There is no difficulty in manipulation of the instrument, and there is easy bimanual dissection. So there is a tubular retractor. The endoscope is placed at one corner at the periphery, either superior, inferior, or onto the side, and then the instruments are passed through it. So you can have various angles. You can angulate your instrument at the, whatever angle you want. So there is a easy bimanual dissection. You can do bimanual dissection as good as microscope, and it is done in the air media. So there is no difficulty in controlling bleeding, and because of these two property, because of easy bimanual dissection and because of control of bleeding in the air media, even large and vascular lesions can be operated through the tubular retractor using endoscope. Now, there are various things available. Different kind of tubular retractors are available. There are large tubular retractor, means large diameter tubular retractor, and there are a small diameter tubular retractor. So people may be confused which one should use. If you have a large tubular retractor, and obviously it may cause little more damage, but there are tubular retractor which can collapse and which are soft, like the one which we have devised. So if there is a raised ICP, these tubular retractor, if it is of 2 centimeter in diameter, becomes 1.5 centimeter or 12 mm in the beginning, and gradually it expands. So the large diameter, there are advantages. The advantages are can use 2 or more instrument because there is sufficient space, and the special instrument which are used in the endoscopy, like a small diameter endoscope, and the slender instruments or curved tip instrument, and the instruments with 2-in-1 function. So the special instrument in which 2 functions are combined in the single instrument, like you can have suction and coagulation, and there may be instrument with the curved tip. So in the small tube, it is very difficult to have a linear movement. So you cannot move linearly, but you can rotate. So you introduce this curved tip instrument at certain point, and then you rotate and you can manipulate the tumor and take out the tumor. So if you use a small diameter tube, and the another advantage of large diameter tube, which is soft, is that if you are not able to do it with the endoscope, you can use microscope and continue your surgery. Whereas if it is a small diameter, you have to have expertise, and you have to have a small space. There is a small space, so you need to have the special instruments meant for these small tubes of 11 millimeters versus the large tube, which can have both the advantage of a small tube, and the large tube can also be modified. So you need a special instrument when you use a small tubular retractor, because the space available is less. So the endoscope diameter also has to be See, think of 11 millimeter diameter tube, and you have to use three instruments, three things. One will be the endoscope. If it is 4 mm endoscope, 4 mm, and then there is one suction, and there is a bipolar. So if you use three instrument in 11 mm, there will be hardly any space to manipulate instrument. So what you need to do is that you need to reduce the diameter of the endoscope. So rather than 4 mm, you keep 2.7 mm endoscope, and the instrument should be slender, or else you have instrument which are especially designed, which have both suction and coagulation function, and then only you can perform the surgery using a small tubular retractor. There are adjuvant, you can use CUSA, navigation, rectography. These are especially helpful when the tumor is firm, and navigation is especially useful. Rectography, in which direction your the important tracks have been displaced, and ICG is important. It identifies vessel, and it differentiate tumor from the normal tissue. So vessel visualization. Also, see, you can use ICG in the microscope, and also you can use ICG in endoscope. So the advantage of using ICG in endoscope is that the dye remains for longer period. So you can visualize things up to 30 centimeter, which is not there in the microscope, but obviously you require special filter. The laser can also be used if it is a vascular, and if you have simulators, then preoperatively you can decide how to go about it. So some of the examples, this was atrial tumor, choroid plexus papilloma in the atrium, and we did not have navigation, so we used marker CT, and then we planned the superior parietal lobule approach, and then at the center of the tumor we put in marker. So these are the pile stitch which I apply when I do in particular, because after draining of CSF, the brain falls away from the dura mater, and it can produce one is that your tubular retractor becomes unstable. Two is that there may be subdural hematoma, the breathing vessel may get torn. So to avoid that, I apply these pile sutures. So this is, we have reached directly on to the tumor. See, in a situation where you don't have too much of facility, you must have seen that I am using the normal bipolar. So normal instrument can be used. And then another advantage is that if you are not able to do things with the endoscope, then you can take microscope and complete your surgery. So this is the pedicle of the tumor, the choroid plexus papilloma, which was coagulated and cut, and the tumor is removed. This provides the constant corridor. The beauty of our retractor is that it just holds the brain, it does not damage. We have not seen any contusion so far, and we have used it in, I mean, thousands of patients. So after that, you should go for absolute hemostasis, and then you can put in drain and come out. So complete excision of the tumor was done. And this is the post-op image with drain inside. The another, I have taken one example of each. So this is the channel endoscopic surgery. This was a suprasellar arachnoid cyst. This patient, you see the large cyst. The patient also had a compression on the brain stem. So we planned the just anterior approach in front of the coronal suture. So you should direct towards the coronals, towards the foramen Monroe. This is the cyst. The wall of the cyst is being coagulated, and then so that it can be cut. And there is no bleeding. In channel endoscopic surgery, you should try and prevent bleeding. If there is a bleeding, then you are in trouble because the visualization becomes difficult. So the cyst wall is being, when the incision is being increased, so the cut is extended on either side. And once you make sufficient cut, then we have gone inside. So this is the basilar artery. This is obstructive type of the suprasellar arachnoid cyst. So there is a arachnoid cyst in front of the basilar artery. So you need to remove the cyst wall inferiorly. So dual fenestration is required in the suprasellar arachnoid cyst, which is obstructive type. The other type, obviously, when the basilar artery is naked and it is in between the cyst wall, then you don't require that kind of. So there is a membrane onto the basilar artery. So carefully it should be removed. Obviously, you should be very careful and you should do under vision. This removal can be done with the rotation and always under. So you see the inferior. So ventriculocystonostomy and cisternostomy from the cyst to this subarachnoid, that is cistern, basal cistern. It has been now the posteriorly. The cyst wall along with the interthalamic adhesions are removed. You should always check the posteriorly. There may be associated malformation. So two fenestration. One, this is the stalk. So one in the ventricle and one in the basal cistern is required, and this patient did very well. So the example of channel endoscopic surgery. Just for the completion, because it was a suprasellar cyst, arachnoid cyst. These are two types. So the example which I have shown was the non-communicating. The suprasellar arachnoid cysts are due to abnormality in the interpedicular cistern or in the membrane of Lillie-Kist. So in non-communicating cyst, there is an intra-arachnoid cyst of the diencephalic portion of the Lillie-Kist membrane, and because there is a cyst there, so it displaces the basilar artery posteriorly. Whereas in communicating cyst, the basilar artery is within the cyst itself, and usually it may not cause symptoms and sometimes may not require even treatment. The colloid cyst, also I do it with the channel endoscopy. I did it in the beginning, but now I do it with the tubular retractor because total excision is possible, and you can dissect the attachment of the cyst with confidence from the roof of the third ventricle. So the same superior parietal lobule approach. Then I put in these gauze pieces so that the blood does not trickle along the tube. The cyst has collapsed because of the raised ICP. This is the colloid cyst, which is there at the foramen Monroe. Coagulation of the choroid plexus and the cyst wall, and then you cut the choroid plexus, separate it from the cyst, and then you also cut the cyst wall, reduce the cyst content so that it becomes small in size. And after that, you can bring that cyst in the lateral ventricle. So separate it by manual dissection is possible, you see. And then using two instruments, you can coagulate, you can cut, you can dissect. So the cyst wall is being separated from the roof of the third ventricle. And whatever a small little, so this is being brought in the lateral ventricle, and those attachments which are there, which otherwise might have not been possible, you blindly pull them, either you rotate them, so it may, you may, take out the cyst, but there is always a risk of bleeding. But when you use these small tubular retractors, and which does not cause any harm to the surrounding brain, which are soft, then the bimanual, you don't have any worry when you are operating. So this is complete cyst excision. So these are some of the examples: intraventricular tumors, preoperative and the postoperative using superior parietal, because this was there in the posterior part of the body of the lateral ventricle approaching the atrium. So we took superior parietal lobule approach. This was posterior third ventricle tumor. So ETV and biopsy was done. The tumor there in the posterior third ventricle, the coagulation done, the biopsy is being taken. For ETV, you keep your working channel. So this was channel endoscopic surgery. You can also do it with the tubular retractor, but we did it in the initial part. So ETV and biopsy. This was a large suprasellar arachnoid cyst, again dual fenestration, and this was after surgery. The compression on the brainstem has decreased. This was a large cyst which we reported in Neurology India, extending from foramen Monroe to the foramen Magendie. So large cyst. So we did only one large fenestration there because we could not dare to go inferiorly and make communication, but fortunately it worked. So the compression on the brainstem, see, the brainstem was thinned by the cyst, but after surgery, the brainstem dimensions have increased and the patient did very well. So large giant arachnoid cyst was removed. There was thalamic abscess. We did by channel endoscopic surgery, but this was in the initial part of my learning curve. There was a little bit of confusion, but this was channel endoscopy, not tubular retractor. So to conclude, channel endoscopy is indicated when there's a small intraventricular tumor and the lesion is small. But if the lesion is large and vascular, you can do still with the endoscope, but use to take help of tubular retractor. The tubular retractor which we have devised is soft and it changes the size dynamically. So this is unique as compared to other tubular retractor, and this uniqueness comes from two things. One is that it is soft, it is a thin silicone tube, therefore it does not cause any damage to the brain, and there is a longitudinal cut on this. So the cut helps in during introduction you can fold it, and when there is a raised ICP then also it gets folded itself. So does not cause harm on the brain, and then when you keep removing lesions then it keeps expanding. But there are some learning curve associated with this. The tube may migrate, so I keep sutures on the outer surface, so that part has been taken care of. The retractor may become unstable. When you remove tumor, there's a lot of cavity produced in massive ventriculomegaly, and when there's a large tumor. So in the end of your surgery, the tubular retractor may become unstable. It falls on one side or the other. So I keep these sutures, place 3 sutures placed at the one end, and that takes care of. And I use pile sutures in such situations so that the brain does not fall away from the dura mater. So these things, plus the dural opening also should be small. So don't open dura too much. So all these things have helps in overcoming the limitations of this tubular retractor. There's a difficulty in significantly changing the trajectory. You cannot change. So you cannot have the trajectory which is lying anterior to if the tumor is like this, so your tubular retractor cannot go anterior to the lesion, and then you might think that I'll take out the whole thing. So place your tubular retractor at the center of the lesion, and then you start decompressing, so you can take out the whole tumor. So planning is important. The trajectory has to be there in the middle of the lesion. The tube should be at about 90 degrees to the floor. If it is horizontally or at a very large angle, 45 degrees, then the overlying brain will compress the soft tube. So there are advantages of softness, but there are limitations of softness, is because if you don't put the tube at 90 degrees or maybe 75 and 100, 115, that is all right. But if you keep the angle too much, then the overlying brain will compress the soft tissue and it will become slit-like. So it will be difficult to work. So I have already discussed these limitations in the tubular retractor. Therefore, I have been not included the diagram. I am thankful to my teachers. Thank you very much. So now I think.
So thank you, sir. As usual, wonderful lecture. You have dealt extensively. You have given us, exactly where to place the tubular retractor in case you use the tubular retractor, the corridors to choose, into the various parts of diaphragm, how to avoid the white matter damage, and how to supplement microscope whenever required. And it was quite very extensive, and then very demonstrative, and then very nicely explained, sir. So as of now, I don't see any questions in this thing, but I think.
Yeah,
there's one question from Manda.
Yeah, one question.
You take the Dr. Swami, sir. Please invite comments from sir.
That's what. So I'll take out the questions later, sir, and let's have the privilege of inviting people, the stalwarts who can do from various approaches and various methods, as sir has already said. Dr. Chandrasekhar Dev Pujari, sir, and then Dr. Avdesh Jaiswal. Your views, please. Dr. Chandrasekhar, sir.
Thanks, Brigadier. I must thank you and Dr. Yadav for this opportunity to participate in this webinar. I must say that Dr. Yadav has very humbly attributed a lot of his learning to me, but he's gone much beyond that and he's dedicated himself to neuroendoscopy. And I'm really proud not only of his work, but also the fact that he has brought the Indian neuroendoscopic world to the attention of the world by publishing regularly and conducting teaching activities. So congratulations, Dr. Yadav. And I think all this hard work has eventually paid off and you have got a very nice super specialty center on neurosciences. So that is a really big achievement. In terms of intraventricular tumor, I think the scope of surgery has been very nicely explained. And if we talk about pure channel endoscopy, I think we are probably constrained only to cysts and probably very soft tumors now that I have had some experience with working with endoscopic CUSA, which doesn't function very easily because it repeatedly gets blocked, etc. But if it works properly, you can remove soft tumors quite easily. And we have described some of that work in our publication. But otherwise, channel endoscopy is really restricted to like what you showed. Ideal indication is like a suprasellar cyst. We also use it for temporal arachnoid cyst, but we are talking here mainly of intraventricular. So that is the most common. And I have used it for colloid cyst, and I know that you have achieved mastery with your tubular retractor, and Dr. Avdesh has gone further, as you said. But in my personal experience, I think for people who do not use endoscopic surgery regularly, especially the endoscopic guided or whatever the other name you have given, endoscope controlled surgery, I think it can be difficult. If you try to remove colloid cyst through a channel endoscopy, which is very tempting, occasionally it can be troublesome if the cyst has inspissated material, hard material, which you cannot easily take out and cannot decompress. So that is one caveat, I think, which must be explained at least to people who are starting out. And therefore, other methodologies work quite well. In terms of other tumors, especially posteriorly placed tumors in lateral ventricle, there is a slight variation which we do rather than going through superior parietal lobule, which we think can create a few disturbances. Especially on the dominant side, we try to use parieto-occipital sulcus. And that gives us two advantages. One is most of the pedicles of tumors, like choroid plexus papilloma or meningioma, are mainly coming from, medially and inferiorly. So you actually reach that part of the tumor first when you introduce your tubular retractor or when you make the channel. And that makes it easier for us to take hold of the pedicle. You may either divide it or just extensively coagulate it before you start debulking or removing the tumor. Many a times, if you do not use a tubular retractor, you may have to piecemeal remove the tumor. Apart from that, I think you have described most of the techniques quite well. I would still say, like you showed in your initial slides, that for people who have started out in endoscopy or for the first 20 cases, you should probably restrict yourself to smaller avascular cystic tumors. And then probably once you have done 20 good cases, you can proceed further. And I'm sure Dr. Jaiswal will have a lot more to add.
Thank you, Dr. Pujari, sir. Very good point you suggested. Attack the pedicle first and make it avascular and then remove it. And definitely good suggestion, to go for avascular tumor in the beginning and then go for vascular tumor so that you can deal with it. Definitely. Let's have views of Dr. Avdesh, and he has been a master of removing large intraventricular tumor.
I'll just like to come back to one more comment that I use a lot of combination of endoscopic and microscopic surgery, what you call endoscopic assisted surgery. even for larger tumors, vascular tumors, etc., to devascularize them, and most importantly, to make sure that you have removed the tumor completely, there are no blood clots. So our percentage of putting EVDs have reduced considerably, and post-operative complications have reduced considerably.
Definitely, sir. There is no hard and fast rule that, once an endoscopy is used, you should stick on to endoscopy. Otherwise, what people are going to think. Ultimately, it's all the patient and then the ease of surgery to make it avascular and then remove it. It's a very good point, sir. Let's have comments of Dr. Avdesh, please, now.
Thank you, Dr. Yadav, Dr. Swami, for giving me this opportunity. Actually, I just want to know from Dr. Yadav, sir, I have seen that when you use your tubular retractor, it automatically gets folded on its own. And thereby, the lumen of the retractor also becomes small. So how do you manage it? Because the working channel becomes even more smaller.
Yeah, you are right. So in the beginning, you have a less space. I told you that there are small tubular retractor. There are people who use very small tubular retractor. So when you have less space, you cannot do linear movements. Bimanual dissection becomes difficult. So use angle tip instruments. So that is absolute must. And then when you introduce angle tip instrument, if your suction is already in, then you cannot put in angle instrument because that diameter does not allow. So, so keep angle tip instrument first. Maybe you keep your endoscope outside little bit and then gradually go inside. So there are some tricks which obviously could not be discussed. But there is in the beginning when the pressure is more, then the tubular retractor size becomes the 2 centimeter might become even 1 centimeter, and that should be there. So you are right. And sir has already said, I am also of the opinion that there is no hard and fast rule. I mean, it is not that I will not use microscope. So if you find problem, the advantage, there are advantages of microscope. I'll discuss in my next presentation, the difference between the endoscopy and microscopy, the advantage and limitations. The advantage of microscope is whatever space you have available, 1 centimeter, 2 centimeter, whole thing is available for instrument manipulation. In the endoscope, there is a limited space available, and then some space has been eaten away by the endoscope. So the instrument manipulation, so you have to learn a trick. So linear movement is not difficult. You can use angle tip instrument and use little rotation technique to complete your surgery. And once you keep on removing, the CSF comes out and the tumor also comes out, then you can. So my answer to your thing is, if you find problem, use microscope, and once you get little more space, the tubular retractor enlarges. So there are limitations of the tubular retractor, at least of my tubular retractor. The other tubular retractors are stiff, so they don't collapse. But mine has the advantage. I call it as an advantage. There are limitations also, it collapses. But the main point is that the brain should not get damaged, which I always focus. That with now experience of so many cases, I can manage. In the initial, I used to take microscope sometime to do the initial work.
I will just say something, Dr. Swami, with your permission. The question Avdesh asked is very important because he manages to operate without it. I think what is important is to keep the channel patent. Because if the channel does not remain patent during surgery, you can get into serious trouble. And therefore, the attempt to use the retractor, tubular retractor is mainly for that. But the biggest advantage that it gives you is that, especially in people who are again initiating in this, every time you put your scope and instruments in, you can damage the brain. So tubular retractor, either foldable or unfoldable, gives you the biggest advantage that the channel does not close, and it allows you to take out your instruments and put in your instruments several times without causing any damage to the brain. In soft retractor, I have tried to use it sometimes, what Yadav has said. I think the advantage is the same as we do not use retractor. Why we do not need to use retractor? I have done retractor-less surgery, endoscope controlled quite a few times now. We managed to keep the channel open by use of endoscope in one end, by use of our suction on another end, and by our dissectors. So there are three instruments which are retracting the brain. The only disadvantage of using this system is that you may occasionally damage the structures, which can be avoided if you use his foldable retractor. I think that is what I have understood of this technique.
Yeah, I've been seeing sir, and then I've been assisting sir, Dr. Avdesh. What I think is the end of the tube, the tubular retractor, doesn't get folded. What sir does is he keeps it at one place, removes the core of it, and then he draws the other peripheral tumor to the center, and then he again operates on it. So that the tube remains the patent, and the millimeter of the diameter of the tube is 1 millimeter, 2 millimeter, 3 millimeter. It's quite stiff enough. It doesn't get folded. Okay, that's my personally what I see. Okay.
Actually, let me tell you, if somebody want to operate try endoscopic surgery for intraventricular tumor, I think before they should operate at least 10 cases with microscope. And
agree.
then
One has to be microscopic surgeon before.
And
that's
they should know how to manipulate instrument, how to handle the tumor with the microscope, and using retractor, fixed retractor. And after that, they should start using start with small tumors and cysts, what Dr. Dev Pujari and Dr. Yadav has told. And then after they can do either tubular retractor or tubular retractor-less surgery. But definitely they should have mastery, because if you directly jump on using tubular retractor or using retractor-less surgery, so there sometimes internal tumor are very bleeds a lot and become very difficult.
yeah,
So
certainly.
what I meant to say, and one should never hesitate in using microscope if there is a problem, because the goal of surgery should never be compromised. Whatever approach you are using to remove the tumor, the goal of surgery should never be compromised.
Certainly. Thank you, Dr. Avdesh.
Very well advised.
Yes, please continue.
No, nothing. You complete your thing, please.
What I am saying, why I don't use tube retractor, basically that this tube, what Dr. Dev Pujari has told that the tube provides constant pressure, though it is less because it's soft, but still it is constant pressure, and the endoscope, suction, as well as the operating instrument, they provide dynamic pressure in the tubular retractor-less surgery. So, but other thing that the opening of the corridor is also very important, what Dr. Dev Pujari sir has told. So the assistant role become very paramount in this. He holds the scope and at least retracts the keep the channel patent by using endoscope as a retractor. And I have to make the assistant very comfortable also. He has to be very patient. So that's why, and the other most important thing, that how to introduce the instrument in the at the target area, because you see only the tip of only the target. You do not see the this is the drawback of the endoscopy, that you do not visualize the proximal structures proximal to the target area. So you have to use your position sense, as well as you should follow the suction tube, because suction is in other hand. You just use your instrument and follow through the suction tube, and it will reach to the target area without damaging any sites of brain. And yes, it required another set of skill. And once you keep on doing it, you learn it. It's not very difficult job.
It's agree that one masters what he sees and then what he keeps on doing.
Of course, of
both
course.
the techniques are good.
No, there,
Yes, but
there is
in my
also
mind-
one big advantage. If you are by doing bimanual surgery endoscopically, one of the ways the instrument goes in proper place is there is mental navigation. Your
Yes.
both hands know which hand is going where. So if one hand is pointing instrument to one place, the second hand automatically takes it there. You just need a little bit of training and it happens. So I call it mental navigation, but I'm sure there must be some other good word for it.
But sir, let me tell you, the role of assistant is very important. I always keep on, saying that the assistant, that if you have any problem, do tell me first. And I keep on irrigating intermittently, not only the target area, but the surface of the brain also, because otherwise the bridging veins get dried up and it may lead to hematoma formation. But Dr. Yadav sir, you have explained very well. It was a really very nice lecture and I enjoyed it.
Very comprehensive.
Very comprehensive. It has covered everything.
Thank you.
Thank you,
Thank you. That's all.
I think this discussion has answered Professor Arshad Mehta's answer that he has asked, in case of meningioma, do you use only endoscope? I think we all are given up. It's not a must. Whenever you require, you take a microscope and then do it.
Microscope also can be used,
Yeah.
but you use, interruption of blood supply. There are other questions also.
Yes, and Dr. John wants to know whether you use EVD in every surgery. That also you have answered. That if the thing is avascular and then there is no risk of hemorrhage.
We should tell each and every, do you place ventricular catheter at the end of surgery? Yes. When we feel that there is some oozing, then we keep EVD, the catheter at the end of surgery. Dr. Juan said,
I'll read out, sir. I'll read out.
yeah, routine, but not routine in selected cases. How exactly the pile sutures are taken? I take 3 pile sutures. So the sutures are passed through the pia and then these are tied with the dura so that it doesn't fall, the brain does not fall. So I use these sutures. I use Vicryl for that purpose 40, and sometime I supplement it with the tissue glue also. So use pile sutures and then put some glue there so that the brain does not fall away from the dura mater and cause my tubular retractor unstable, number 1. And number 2, this may also cause bleeding from pile vessels. From vessels.
Yes, Dr. Abrahaman wants to know, in case of obstructive symptom, do you do shunt and collapse the cavity, ventricular cavity first and then go with the procedure?
No. If there is a ventricular dilatation, I think it is better. Unless, it should be done only when the patient is in bed. You cannot operate. You are, in government setup, we have a long waiting list. So we do shunt only when the patient is bed. Otherwise, try and avoid do shunt in the intraventricular lesions. If you do shunt, then there is a problem. You need space to do surgery, especially endoscopic surgery and other surgery also. So
I feel that moment you enter the ventricle, the CSF is being released.
yes.
Because the ventricle, much better the access is. So
Right.
So we don't have any questions, sir. And then
So
panelists, if they have some other views, who can exchange regarding something which has been left out or probably add on something.
can pia be coagulated with the bipolar to the dura? Yes, but I apply suture and then with this, I think yes, can be done, but then the possibility of this getting disrupted during surgery are high. So I use suture and I supplement it with the tissue glue sometime. Also, especially when there's a huge ventriculomegaly. You may not use it when there is a very small lesion and the ventricular dilatation is not too much.
We have no further questions, sir.
I think
you.
Avdesh wants to say something.
Please,
Brigadier.
please.
Yeah.
Most
Sir.
welcome, Dr. Avdesh.
Sir has covered everything. I think nothing is left now.
Your hand is still raised.
I think it was
By mistake. By mistake.
Okay, sir. So I
We
think
thank everybody. Thank you, sir.
start.
Thank you, Dr. Pujari, sir. Thank you, Dr. Avdesh, and thank you, Professor Yadav, sir. As usual, wonderful lecture, sir. Very educative. Thank you, sir. And thank you, John, for providing us this platform. John, are you there?
No, I'm not there. I fell off here. Hold on.
Yeah, please come. Please come alive.
Oh, can you hear me?
Yeah, we can hear you.
Hear you,
Okay,
John.
I
Are
guess-
you busy in some other meeting?
Yeah, we're finishing.
Yeah, okay. Well, thank you very much, everyone. Again, another webcast of a lot of interaction, which is me, the thermometer of how good the broadcast is. So we'll see you all next week.
Thank you. Thank you.
Thank you very
Have a
much.
good day,
Thank you,
John, and
Brigadier. Thank
good
you,
night.
Dr. Yadav.
Good night to my panelists and good night, sir, Yadav, sir.
Thank you.
Thank you.
Thank you. Thank you.
Thank you, sir.
Good night, Dr. Arshad.
Harshad
Thank
sir.
you. Thank you.
Thank
Very nice presentation,
Sir.
as always.
We'll leave you guys. Thanks.
Thank you.
Sir.
नहीं अभी आता हूँ
Yeah. So I think leave meeting.
Is anybody still here?